Thanks everyone for being here. I hope you get some benefit from today. This has been like I wanted to chat about things that we usually don't talk much about related to concussion. So things like mechanism related to the physiology behind it, and then how we approach symptoms in general. So there will be some touch around this SCAT, but there wasn't any extensive review of how we deliver it. But in general, I think the whole information will be applicable. So I'm just going to get started. And if there is any questions, you can just interrupt me. I will be happy to answer. This is a discussion about concussion. Concussion actually does have a lot of definition. Like there are 4 or 5 societies between neurology, between physiatry, between the CDC, and between also the sport medicine community that's been putting definitions for concussion. These ones, they tend to be a lot more like similar in about 90% of the time, with some differences in how they define the symptoms with it. In terms of for our sport concussion, this is the SCAT definition, which is in general is going to be more of a transient loss of brain function, and that's, I would say, the core thing about the definition. That sometimes includes some cognitive issues, things related to dizziness. It might also include brief loss of consciousness or amnesia. But in general, all of these things will be regarded as reversible, and also they don't have any finding if someone would do a CAT scan or MRI for these brains, nothing will show up. And the thing about also the important thing about definition of concussion, concussion sometimes might show up after 24, 48 hours or more. So there might be a trauma and someone might present later on in a few days mentioning symptoms that might be explained as a concussion. The other important point with concussion, we don't need a direct head trauma. So it can be things related to any other transmitted force that get transmitted through the body. This is what these are, I would say, the multiple communities that basically been also dealing with concussion. There is a lot of work with the neurology in general community, and I will touch on this in terms of how they approach the symptoms. Also, the physiatry is one of the communities that did a lot of work on concussion. There's something also new going on, which is, it's not new, but something I would say I didn't hear much about even during the fellowship year. This is a community called Enigma. I'll go on the next slide and I will talk about it. But both the Enigma and the community of physiatry, they do touch on the fact that sometimes repeated concussions will result in a long-term outcomes subsequently. So these are the long-term outcomes that these people sometimes touch on, and this is more still a research-based. So the Enigma is this enhancing neuroimaging genetics. These are a society down in the States have been doing more advanced imaging, which is something more than the MRI or the CT scan. And they have been noticing some changes that mostly include in the white matter of the brain, that in their research, they are saying these ones actually, they don't go away. And that's why they warn against more cumulative. But this is in general, this is still research. In terms of the SCAT look, or the community of the sport medicine groups around the world, their consensus was this is still, we don't see any casualty in it, and it's going to need more research. So that's one of the things, if anyone interested or have questions in that regard, this is where things stand now in terms of the long-term outcomes. Sport medicine, we still don't think there is something that will last for longer or tend to be really cumulative. But the last recommendation from the SCAT that this is going to need more research to be confirmed. All right, and now to the fun stuff. So the pathophysiology of concussion. Most of the time, like we say, yeah, concussion is a brief disruption in brain function that sometimes results in, let's say, yeah, loss of consciousness, or someone feel dizzy, or someone feel headache, or having some photosensitivity, or all of these things. But why this happens? There are five pathologic mechanisms that usually happen in the brain whenever there is trauma. Everything can be explained by the fact it's similar to, we'll say, it's just like a muscle contraction or the heart, how the heart beating. There's always ion balance on the brain cells. And sometimes the trauma results in a process called mechanoportation, which is just a small holes happen in the cell membrane because of the trauma or because of the deformation. And eventually, whenever there are these holes, there is some exchange between potassium and calcium along the cell membrane, and this is basically results in depolarization, which is, it's just like when we have depolarization in the heart or depolarization in the muscle. The thing with these, it happened on a little bit more a mass scale in a lot of numbers in the brain cells, and this is in itself trigger a bit of immune what you'll say chemicals release, which is the glutamate, which is this is a hormone that a chemical that's how the brain cells talk to each other. And but this results in some flooding in this. So it's sometimes people describe it as similar to the mechanism of the migraine. Migraine in general does have this rapid pulse of neurologic dispersion that result in the migraine, but with concussion, it's a little bit more of a wider scale that happens in the brain. And because this happen, the brain cell use a lot of energy, and it usually take time for the energy to rebalance itself. And this is when we see here, it says there is some hypometabolism phase in the brain that lasts about 10 days. And this is actually where coincide with in general, like the usual concussion usually recover in about 10 to 14 days. That's the expectation. If someone had a concussion, you would expect them they're gonna get better in about 2 weeks. And this is, I would say, the biologic explanation behind it, which is, yeah, there is more changes in the cell membrane, the cell lose energy, the mitochondria metabolism get a little bit affected, and until it builds itself and start firing up again the way it should be, it takes that number of days. Other, I would say, mechanisms, there is something we call cytoskeleton, which is the axons that usually connect the neurons between each other. They do have protein fibrils that run in them, and these protein fibrils sometimes with the trauma they get deformed. So subsequently, it's going to require more time for these to be rebuilt. Um, Other mechanisms, there is something called the neuroinflammation, which is all the brain in general is being surrounded by glial tissue. So these are like fibrous tissue or things related to the similar to the fibroblast cells, but they are around the brain. So with the trauma, with the injury, they do release inflammatory markers around, and this will cause some inflammation, probably a little bit outside where the impact happened. This is something, as a side note, that usually males are actually more prone to have a larger inflammatory response related to the trauma. The other factor that will result in the symptoms we see, it's more of a disruption in the blood-brain barrier. And this is more of the blood-brain barrier. If you, I'm not quite sure how many people know about the blood-brain barrier, but it is in general, the blood vessels don't really go inside the brain directly. There is more of a membrane in between, and this is where the trauma get disrupted, and subsequently this will result in some immune cells infiltration, some inflammatory response, and that subsequently also results in some symptoms. The last thing that it is as a pathologic mechanism is how the brain cells talk to each other, and these are the synapses. And in general, with the trauma, that results in loss of communication between these cells. So I wanted this to be there because that would explain why these neurologic symptoms that we see in concussion, they tend to be quite different. They are different in scale. Symptoms are tend to be quite large. Like we do have, like in this cat, we have about 22 symptoms that we usually measure with these cats. So this would explain a little bit more of why we are having that much diverse symptoms. And the other factor, they don't happen all in the same region of the brain. So different people have difference of these mechanism in a different region of the brain. So everyone's gonna have a little bit more different symptoms, and they're gonna have also different severity in that regard. Any questions? Take this as a no. And now we go to the, so now we know about the physiology and pathophysiology of it. Mechanism of injury, it's going to be trauma. So the trauma in itself, it's going to be either direct or indirect force, as we mentioned earlier. And the indirect force, these are what happen when it is either transmitted through the body or the whiplash type of injury. In general, the forces are either going to be linear forces or they're going to be rotational forces. The brain is actually more susceptible to rotational forces, and this is usually, if we see it in things related to football or hockey, it's the side impact when people get hit on the side of the head, and then their heads a little bit more rotate. So these are the twisting forces. They tend to be they have more strain on the brain, and they usually result in concussion. In general, any force around the head can result in concussion. In terms of how type of the sports might affect the symptomatology or the incidence of the concussion. Football, rugby, hockey, that's as expected. It's high velocity collisions. There is something it's been also being studied now, even with the SCAT community and with the other communities, that's a lot of research around, which is the repetitive subconcussive impact that also might predispose to an episode of concussion later on. So these are, for example, soccer players who usually hit the ball a lot through the game, and then they might present later on with symptoms that might be related also to concussion, which is, cognitive impairment, loss of focus. They might have a little bit of loss of balance, but in general, there isn't really a specific incident that would cause these symptoms. The other factor with these subconcussive trauma is if someone gets more repeated trauma during a game, or he'd been playing for a month and he'd been having these repeated injuries, it might also predispose them that they might have like a real impact that would result in concussion because they already a little bit imbalanced, or they already have a little bit loss of attention. And in the other sports, which is the combat sport, these ones they present more quite obviously differently, which is more loss of consciousness. So most of these, they are one hit direct trauma to the head, and it results in loss of consciousness, which differs from other type of sports. How we diagnose concussion? So concussion in itself, it's a clinical diagnosis. It has nothing to do with the SCAT. It has nothing to do with any of the measures we do. So if someone gets hit and on the sideline, their SCAT also might be normal, they might still have concussion. So concussion diagnosis is more than just a scoring sheet. This is the American Society of Physiatry, and this is the what you say the clinical feature that has been followed by our Canadian Concussion Collaborative, if anyone heard of this. So this is what they are following in terms of how we diagnose concussion. I can not gonna read all of these things, but in general, it's mostly a clinical science, and then it's going to be confirmed by lab finding. And by lab finding, we means this is where we can do our SCAT, or we do any other assessment tool that would assess the severity of the symptoms. Any questions here? 3, 2, 1. Okay, so in general, I will say it's either video evidence or we see the player, or if it is being reported in terms of history, observation in terms of clinical sign, what people might have. Did they have more of have the dazed look? Sometimes they have loss of memory. Did they have loss of consciousness? Tingling numbness sometimes also being reported. The other factor is also the subjective symptoms, which is if someone came and say, I feel dizzy, I feel I cannot focus, I have problem with vision, that also would be taken into account in terms of diagnosing concussion.
And Asaad, we did
Yeah.
have a couple of questions just pop up in the chat.
Sure.
So kind of two questions actually. One about, can you tell us a bit more about the elevated blood markers for a concussion? And then kind of adding to that, any risk of false negative or positive type, false negatives or false positives with that.
Blood markers. So blood markers in general, there isn't really anything being used clinically for now. So all the blood markers up to now are mostly research tools. So we don't have really anything in the clinical realm that will help us diagnose concussion in that regard. Is this what I understood in terms of blood markers, or is there something else?
Yeah, Lisa or Fraser, do you want to kind of elaborate a little bit more on your question there about elevated biomarkers, sorry? You should be able to just mute yourself. Oh, okay, so
No, they lead blood markers.
oh, okay, so yeah, more.
Oh, so the lab findings here, it's actually it's going mostly with the what we are following here is just our physical test. The elevated biomarkers, these ones are it's not part of the like at the moment we don't really have none of the societies would include them in their diagnosis. These are mostly research tools up to now, in general. So we don't have a blood test that will, like in terms of like clinically, there is a lot of research going on. Some of it even with the being published with the SCAT 6, but these are in general they are still being listed under research. Hope this helps. Okay, let me move in. Concussion, we usually don't need imaging, but part of the recommendation here, we still consider concussion is on the spectrum of basically traumatic brain injury. And it's usually part of the minor or the mild traumatic brain injury. So if we go to the division of traumatic brain injuries, we have mild, moderate, and severe, and these are usually get classified according to the GCS score. So the mild is usually between 13 to 15. That's the GCS. Concussion will be considered more of on the spectrum of the mild or a mild form of mild traumatic brain injury. So in general, if we wanna manage it as a clinician, we still have to apply the Canadian CT head rules gonna come in. So does this patient need imaging? So it's more of we don't want to just be more focused around, yeah, this is most likely concussion. It's more of trying to consider other factors. Is there something in the presentation that make us worried? Do they fulfill some of the Canadian CT head rules that would qualify these people for further imaging, and they probably going to need to go to a hospital? Other factors that comes into a play, are they anticoagulated? That's also an extra consideration. There's also been mentioned, well, if someone presented a few days later, they are having also, let's say, symptoms of imbalance or maybe a weakness or some oculomotor disturbances. At that time, it's most probably they might need an MRI if there is a concern that they might fit the Canadian CT head rules, if there is any worry. I will just put here, just for more of a refreshing, this is what the Canadian CT head rules, which is basically, it's kind of more easy to find, and we can just check if someone qualify to any of these, and if that in that case, they probably might need imaging within a timely manner. Canadian CT head rules is one of the things we apply for adults up to the age of 16. And then below 16, we usually have the Peckran CT head rules. So this is in kids. If we are worried that this is something more than concussion, in that regard, we have these rules that will decide, do these people need imaging or not. So the Peckran is basically related to if the child is more than 2 years or less than 2 years of old. So this is more of just a reference, just for the sake of thinking of concussion is as on the spectrum of traumatic brain injury, and sometimes people might need more than just concussion management. Okay. Concussion does have more of a globally, it's been estimated to be about 74 million cases per year. And considering that about 20% actually of concussion cases might take longer to recover and being classified as post-concussion syndrome. So it is quite large number of population that's probably gonna more get affected by concussion, or make it more, the management of it make it important. The way we approach it, how we want to deal with the symptoms is also important. Part of the epidemiology is what's been mentioned also in the literature is the gender differences, and sometimes it's related to the type of the sport, or it's also related to age group. So children in general, they are more prone to concussion, and the reason why is their head tend to be larger, their neck is weaker. So they tend also, when their brain is immature, the axons and part of the brain is still unmyelinated, so they don't have complete neuronal connection, and this will make the concussion a little bit more severe. Female also in certain sports, especially nowadays, it's been mentioned the incidence is increasing in soccer and female playing soccer, and it's unclear whether this is related to this repeated more head like heading the ball and adding this to a weaker neck might predispose also the females to a higher rate of concussion. There is also research related to the time that the concussion happened around the menstrual cycle and the progesterone level in the blood. That's also might affect the severity of the concussion. All right, now probably to everyone's favorite parts. So we talked about concussion physiology, clinical signs, and then now it's how we assess it, how we assess the symptoms. So there are multiple assessment tools for concussion. The SCAT is actually one of them. It is the one we use most of the time, and it is the one widely used and being adopted. So everyone is familiar with the SCAT. It's 22 symptoms. We do have cognitive screening. We do have neurologic screening, which is related to balance coordination. We do have the memory screening, and we also have the level of consciousness. There's other assessment tools. The VOMS is actually now, it's kind of more being, we are using it in the sport medicine clinic, even as part of the SCAT. There is still research going on at the UFC about things related to VOMS. So this is the vestibular ocular motor screening. These are actually the symptoms that usually appear earlier in the concussion. So sometimes you can even do them at the sideline, which is especially the pursuit, the SCAT, and trying to elicit if the athlete's gonna have symptoms with the repeated movement. It's more confirm also the diagnosis of concussion quicker. The VOMs also help. Here it's mentioned more. We need to identify the vestibular dysfunction. If we identify it earlier and target it with therapy earlier, this will reduce the incidence of post-concussion syndrome. So the problem with these, if there are some symptoms that we leave for later, for example, patient don't have earlier therapy or they don't connect with therapist for that regard, it might also propagate and might leave people with more post-concussive symptoms. Right. Any questions about the VOMs? Everyone familiar with the VOMs? Everyone done VOMs before? Questions in the chat? No. Okay. So the VOMs is actually quite interesting to do. Then see, other assessment tool is the impact. I'm quite sure everyone have heard, or a lot of have heard of the impact. This is more of a computerized neurocognitive testing, and most of the some of the athletes, the ones in UFC, they usually have a baseline impact assessment, and then subsequently, if they have concussion, they do have impact later on to see if they came back to their baseline. So that's more provide us a little bit more quantitative data that help in comparing and help also guide the return to play decisions. The impact in general, it need to be done within the first 3 days, and it also later on be repeated in about a week. We can always repeat it as later on in the course of treatment to kind of more gauge the progress. But in general, no single test of these tests we are discussing here are basically the B1, like be all, like it's something that will decide someone gonna really kind of stay away from play or will be cleared out. Sometimes people might score well, they compensate very well during these tests, but there is still clinical concern that they are, sorry, they didn't recover very well, and at that time we still might have to hold them back. Right, there is another assessment tool that has been used on this sideline. This is also a proprietary, basically, a program or application. They applied through a tablet, and it's called the King-Devick test. It includes a screen with multiple numbers, and then the player have to have a baseline and go back if there is an injury and suspected injury. They go back and read them, and then they will compare their results, or if this will cause any symptoms. This in general a little bit similar to the VOMs, which include more saccadic eye movements, which is the eye gonna jump from one number to the other, and then go through a timeline of a test, and then they will check their times or symptoms.
Asaad, we had another question here, if I may. Do you know, or does anyone know if there's any reason behind why a concussion might affect exercise ability more for some people versus more vestibular function for others?
Right. So by exercise, you mean like running, walking, or exercise? Because the exercise is usually connected mostly to either ocular or vestibular. So what's their symptoms with the exercise? It's usually if either they have headache, or they may have symptoms related to imbalance, or they might start having symptoms related to photophobia or problem with vision. So exercise more of it's a complex thing that require system. Yeah. So headache. This is actually also very interesting. It's an interesting question, and you kind of gonna make me answer my probably another 10 slides down the line. So actually headache happen in exercise because most of the time concussion actually, like the neurologist, like this is where the weird neurology people kind of look at the concussion. They are saying is actually concussion mostly affect vestibular and ocular, and all the other symptoms are actually results of these ones. Because um, if we want to do exercise, we actually have to use our balance inputs, and our brain have to coordinate all this information coming in. And as we mentioned earlier, when we have all these connections are not really firing up the way they should be, this will result more in symptoms related to headache or symptoms related to some autonomic type of disturbance. And the same goes with vision. With exercise, we also might need to stabilize ourselves in the environment. There is a little bit of jumping up and down or running, and all of these information for the brain to process. It's going to need more intact sensory inputs that's coming from the ear or coming from the eye. So saying that, this usually results in things related to headache. But if we say someone really doesn't have any vestibular symptoms or ocular symptoms, but they usually have headache, most of the time these people are coming from cervicogenic headache. So the ones that usually like the explanation is usually most of these people, their headache might be related to a cervicogenic, which is more of a whiplash related type of injury, which is this occipital pain that radiates. So that would explain like why some people have different symptoms, because the parts which are injured are also a little bit different. Does this kind of answer a bit of the question? Okay, we'll move on. So these are, this is the concepts which is coming from the neurosurgery or neurology community. In their assessment, they will consider concussion is more of, there are subtypes of concussion. And this is basically, I will say, building on the uh, like on this earlier question. So some people are actually have more predominant cognitive symptoms. Some people have oculomotor symptoms. Some people have more headache and migraine related. Some people have vestibular, and some people have anxiety and mood. And there is one thing that also they were suggesting, some people have also more sleep disturbance. And if we want to go back to the pathophysiology, which is how different parts of the brain get affected to a different extent, that would explain that there are some connections in the brain that might be dealing with cognition that usually gets injured in the during the concussion. So as we mentioned, concussion is also like you have different forces. You have linear forces, we have rotational forces. So the side of the impact where the shear forces happened inside the brain, which nerve fiber tracts inside the brain that got affected, all of this results in different symptomatology. And that's why some people are going to come and have predominant, for example, migraine. Some people might have predominant oculomotor with a little bit of headache, a little bit of vestibular. The analogy that we can draw about this, think of concussion, things similar to a knee sprain. Knee sprain is actually means nothing. Like if I say this person has a knee sprain, well, what got sprained? Is it their MCL? Is it their LCL? Is it their meniscus? Did they have their ACL ruptured? So if we take concussion in as a sprain, concussion itself by itself doesn't really mean anything. It just means that the nerve fibers inside the brain got affected. Which one really got injured more? It might be the oculomotor, it might be the vestibular, it might be things related to the headache and migraine, which are these are the nerves that coming from the C1 and C2 that help stabilize the head on the spine. And we go back to the same knee sprain analogy, which is, well, sometimes when we injure the knee, it's actually not only the MCL get ruptured. We also get a little bit of tweak on the meniscus. We might get also the chondral lesion with the patella, but it is predominantly an MCL. So we're going to treat it as in a little bit more focused treatment. And the recommendation with the concussion, we're going to deal with it in the same manner. So the idea of all of these concussion assessment tools is basically we want to discover which part it's really affected, where we can help these patients. So if someone comes and they are predominantly related to balance, so we do the modified balance assessment and they are mostly having some vestibular issues, we can target this to start with as, yeah, we're going to focus on rehab related to vestibular function as early as possible to help them more regain function, rather than more trying to get lost with the other ones, and then there will be delay in the treatment. And these are the ones that usually end up with more post-concussive symptoms. And going back to the knee example, we also have different grades, for example, let's say an MCL sprain. So there are people with mild, moderate, or severe. And that's why with concussion, there are people who have their vestibular issues might correct within a week. There are people who are a little bit more injured and they probably going to need a little bit more babysitting and more exercise in that regard. And they will require a little bit longer treatment. Does this make sense? Okay. So going back to the exercise example, there is one thing that we usually tell people to do. So the recommendation now, we don't want people to stay away from physical activity. We try to get them back as soon as possible. So yeah, it's a relative rest for about 24 hours and then just start doing aerobic activities. And aerobic activities are very important in terms of regaining function and helping recovery. There is a difference between if I want to tell someone after concussion and tell them, yeah, go and, for example, on the treadmill and run. And if I want to tell someone, go on a stationary bike and do exercise. Which one you guys think it's better? Or do they make any difference? We can vote through the chat. Who pick the treadmill? Who pick the bike, the stationary bike? I'll wait. Okay.
Looks like stationary bike is the winner so far.
Wins. Yeah. So that's in general goes to the same, which is the idea of concussion. It's usually the most parts which are affected is oculomotor, is vestibular. So by putting someone on a bike, they don't really need to use these things. They are still defective, but they are not going to impede with their cardio function. And the cardiac function is usually whenever there is aerobic exercises, is the idea is you're going to improve the blood flow to the brain. And because there's also something I didn't mention with the pathophysiology, with the concussion, there is a regional difference in the blood flow that happens. And this is related to the inflammatory response around the areas of the brain that get affected. So with the concussion, there might be some areas that tend to be more of, what do you say, not less perfused, because they did the research and they found that the blood volume that's flowing through the brain is actually the same, but they think the velocity of the blood flow in the regions that is affected by concussion tend to be slower. So the idea of trying to put people back on a physical activity is also to improve the perfusion. And yeah, as everyone mentioned, that's correct. It's basically we want to eliminate the use of vestibular and oculomotor. That doesn't mean they are actually healed, but we are not using them and try to treat the rest until things progress. Does this? Lisa mentioned it depends on the bike. Yeah, I'm not quite sure. This is in general, like if there is, I can't think of anything that I will say the bike. unless they have another injury. That's also might be a problem. Okay. So in general, so we'll say how people gonna progress. 80% of the people, they usually recover in about 2 weeks. In general, 10 to 14 days. Some people have persistent post-concussive symptoms in about 20%. And these are the ones we are trying to more target early and find, so we can more tailor the therapy according to their symptoms. Factors that affect recovery, it's usually age, usually the younger age, the children. There isn't really studies about, I would say, seniors, let's say above 60 or something. I couldn't come across. So it's usually the younger, gender differences between male and female, history of previous mood disorders, anxiety, depression. There is an important caveat about this, which is interesting. It's mentioned like actually sometimes people have anxiety. Let's say, yeah, you have a college students who do have anxiety. Their coping mechanism is being active and participating in sports. And then they get concussion. We tell them not to go back, and then their anxiety kicks in. And then they will come back to us. They are more anxious, and then we have to hold them back because they didn't recover. So this is one of the things we also have to consider, which is sometimes people actually their symptoms might happen because they stopped doing the activity that they want to do. There is one thing that's here, it's been missed. ADHD put people at higher risk, and sometimes, especially in school children, some of them actually have undiagnosed ADHD, and they basically had concussion because their attention is less than what it is needed. And subsequently, after concussion, they're gonna have persistent symptoms, but these are actually their persistent symptoms might be their own ADHD, which now being examined in a clinical context. So this is also one of the things we keep in mind. As we mentioned earlier, younger age, because it's brain development and it's the brain myelination of the nerve fibers, and the why the female are also predisposed to a little bit more severe symptoms. One thing here as a prognosis, people who present early, who, let's say in day one, and they are coming complaining of dizziness, they found that these people usually take longer to recover beyond 3 weeks. So that's helped in trying to also manage the expectation of the athletes that this might take longer. In terms of rehabilitation, to connect here, it's the focus, it's usually recommendation is trying to pick up on things related to vestibular oculomotor, because these are the things we can help with. Most of the time, the way they, at least from the neurology society, they are saying actually people having cognitive issues and having headache and having all of these things because these two basic functions are not working very fine. They cannot look very well, they cannot track, they cannot have more process information that require them to do their daily activities, and then they will become anxious, and then they will start having headaches, and then so most of the time these people might have also one of these two things that can be targeted with a rehab. And this is where it says, yeah, visual system is usually affected in about 50%. Convergence has been found to be also one of the objective signs that we can assess. And that goes back to the VOMS, which is trying to measuring the distance when people start having double vision. That's also one of the indicators that the visual system is affected. If we found someone earlier having really a problem with convergence, maybe targeting this earlier with vision therapy might help speed up the recovery. And now, yeah, so going back to just to emphasize that the VOMS is more often an important part in the assessment. Here it says And clinically, if we do VOMs and we do impact, we basically kind of more targeted two things that are important in terms of treating concussion. So the impact usually measure the reaction response, measure cognitive. It's like the cognitive part of the brain function, and then we have the VOMs, which is also assess the vestibular and the oculomotor function of the brain. Right. That's more of a little bit more of a repetition of what we said. So vision therapy, that's goes to, it's going to be also more of a patient-centered. So the vision therapy tend to be, the therapists will assess everyone going to be different, and there isn't really one thing that would fit all. So it's going to depend on how severe the symptoms are, whether it's vision or vestibular, and then how much the person can progress. There is one interesting thing, and why we always focus on trying to make sure that the people are has recovered. It's their predisposition either to another concussion, or they are actually having about 45% increase in lower limb injuries. So we have a player, for example, a hockey player or rugby player having concussion, they didn't really recover very well. They go in and then they will end up having an ACL injury because they don't have really a good coordination. They cannot control their muscles. They don't have enough attention, and they will end up with a secondary injury. And this risk, it stays for almost a year if they didn't have a full recovery. Okay, questions so far? Okay. I just wanted to add this just more of in terms of, well, if there is any longer term consequences. So we said we do have the clinical diagnosis, physiology, how we assess it, what are the tools we have, which is between the SCAT, between the other parameters. The longer term consequences, that what we call the chronic traumatic encephalopathy, which is, this is more of a cumulative repetitive traumas to the brain or repetitive concussion, and then sometimes people present with other symptoms related to behavior or cognitive changes. It's important to pick up on these, because these people are going to need earlier intervention in terms of multidisciplinary approach, refer or basically to specialized centers to get this tackled with. This specifically, there is a divergent views about it. So if the first group that I mentioned, this enigma, they are saying there are repetitive residual changes in the brain that happen in the white matter, and they are saying it's mostly happening in the corpus callosum, which is the corpus callosum. It's like, if you see your hemispheres on the background, it's the one that connect the two sides, and sometimes it's a cumulative white matter changes that might predispose people to later on to more cumulative damage with repeated head traumas. The position from the concussion in sport group, which is the ones that we follow with the SCAT, they are recommending more research. There isn't really a clear evidence of cause and effect up to now. So there are the two that they disagree on that aspect of the chronic traumatic encephalopathy.